is depolarization, which means you will see the your QRS complex, right? So in this, if you look below here, right, look at the ECG image. The electrical stimulus is what? That is your straight line. That is your pacemaker beat, your pacemaker. Then in response to that electrical stimulus, you can see where is the annotation? Okay. Anyway, I can't annotate. Okay. So you see the pacemaking line, then you see the QRS complex. So that means that there is a depolarization. And then, of course, there should be generally, once you have that depolarization, you'll have a resultant contraction. So if you just see a pacemaker spike, but after that you do not see your QRS complex in a ventricular pacemaker, or if you see a pacing spike and you don't see your P wave, that means that there is no capture. Okay, all it keeps moving on to another network. Okay, so sensitivity is the minimum intracardiac signaling required. So going by this, which one is more sensitive, 8 or 2? 8 or 2, guys, which one is more sensitive? If I say my pacemaker sensitivity is 8, does it mean it is more sensitive or less sensitive? So 2 means it is more sensitive. That's right. The answer is 2, because that means at 2 millivolts, it is able to detect it and initiate a response. If it requires 8 millimoles, it requires that much to detect it and initiate a response. That means it is not very sensitive. So the lower the number, the more sensitive the pacemaker is. Now, look at this, right? So this is your millivolts on the left, right? So this is from your chapter on pacemaker. So if you look at the first one, A, right, it's about 3 millivolts. You look at B, it's about 10 millivolts. So if your pacemaker is set at a sensitivity of 2, what will happen? A and B, both of them will be sensed, right? Now, if your pacemaker is set at 8, right up here, what will happen? It will only sense the B. It's not going to sense A, right? So the higher the value, the lower the sensitivity. The lower the value, the higher the sensitivity. Okay, I hope this is clear to us. Now, what is threshold? So, two important concepts in pacemaker, threshold and sensitivity. What is threshold? What do you mean by threshold? What do you mean by threshold? Anyone? What is the meaning of threshold? So threshold, and this is again something you need to know, which is basically the minimum quantity of, you can consider it as voltage or charge. Consider it as voltage or energy. Basically the minimum energy which is produced by the pacemaker that will always capture the myocardium. So the minimum energy that the pacemaker has to produce in order to capture, depolarize and capture the myocardium, right? Minimum. So when we say threshold, it is minimum. Now, if you have a pacemaker that has a threshold of 8, right, versus threshold of 2, which one is better? So, threshold of 2 is better, right? Because if you have a threshold of 8, that means you require 8 volts in order to capture. If you have a threshold of 2, you require 2 volts in order to capture. So the lower the threshold, that means the better is your pacemaker and the better it will function. All clear on this? And one of the things that we always look for when you're assessing your pacemakers will be an increase in threshold. An increase in threshold means that, let us say today when I tested my pacemaker at 2 volts, it was able to capture the myocardium. The patient comes back after 1 month. Now, at 2 volts, it is not able to produce a depolarization and a capturing of the myocardium. It is requiring 6 volts to do it. That means the threshold has increased. So what could be the cause? And there are many causes. It could be that the lead has gotten separated from the wall. It could be there has been some scarring and endothelialization around the end of the lead. So it could be any number of things that has affected the ability of the pacemaker to be able to capture the myocardium. So if the threshold goes up, if it was low and it goes up, that tells you there is some problem with your lead, either your lead position or lead fracture or endothelialization or something has happened. So a rising threshold is never a good sign. Remember though, when you put a pacemaker, for actually the first few weeks, threshold does go up. And that's because there is some scarring, endothelialization and all happening. And then it settles down again. So after about a month, whatever is your threshold is your threshold. Then if it starts going up again, that means Houston, we have a problem. So threshold is the minimum quantity of energy produced by a pacemaker that can capture the myocardium. The lower the threshold, the better it is for your patient. Okay, all clear on this? Now, how do you set your output? Now, this is, the pacemaker that we use in the ICUs. I think most of us will have similar pacemakers. Now, how do you set the output? So you can look here, you can either have the one on the left or the right. These are both temporary pacemakers. So I put it to show you here, because look at the one on the right. You have output, and in this case, it's in voltages. As I said, it could be your output atrial output V, and you're sensing in millivolts, ventricular output V, sensing in millivolts. So how do you set your sensitivity and how do you set your output? So let's start with output. How do you set your output? What is the typical setting of your output? Anyone? Today nobody wants to answer? Scared to guess? So how do you set your output? So I assess my threshold. I find out what is the minimum voltage that I need in order to capture my myocardium. That is my threshold. Now let us say my threshold is 2. What do you want to set your output at? Anyone? My threshold is 2. What do I want to set my output at? Will I set it at 2 or will I set it a little higher? Give myself some security, right? So 2 threshold, remember, is minimum. It is the minimum required. So once you have your threshold, you will always put your output a little higher because you want to give yourself a little bit of a buffer. Threshold is minimum that it will capture, but hey, I'll go 1.5 to 3 times that threshold. So if your threshold is 2, then you can put it at 4 or 5. If your threshold is 3, you can put it at 6 or 7 or 5, but you're going to go higher. Typically 1.5 to 2 times, up to 3 times the pacing threshold. Clear? Now similarly, sensitivity. Let us say I find that this pacemaker has a sensitivity of 2. What should I set my sensitivity at? Should I set it at 1 or should I set it at 3? Anyone? So you will make it more sensitive. So if it is the sensitivity threshold is 2, minimum you can sense at 2, then you set it at 1. If your sensitivity is 4, you set it at 2. You always want it a little bit more sensitive than what is its minimum sensitivity, because you're giving, basically we give the pacemaker and the patient a little bit of a margin. So it's important to get your basic threshold, which is your minimum energy required to capture, then set the output at 1.5 to 3 times that. Similarly, you assess your sensitivity and then set your sensitivity at half of that value so that it's a little more sensitive. All clear? If this is pacemaker for the first time for some of you, these concepts, even after many times, it takes, you keep revising it and getting to be a part of you. So I was going to go over how we test for threshold. Are you guys up for it? Because it's already been 40 minutes and this is fairly complex. I need you to stay with me. I don't have all the answers in there. So anyway, let's try this. If not, we'll come back for a second session on this because there's much more on the pacemaker. So how you test the threshold. One thing you have to remember is that if the patient is pacemaker dependent, for instance, let's say he comes out of the OR and he's in complete heart block and he has no ventricular rate to speak of, and the minute his pacing stops, he becomes hypotensive. This patient, we are not going to test the threshold. This patient, you're going to just put him on a VOO mode, which is no sensitivity. You're just going to pace and you're going to put him on some output that captures his myocardium, and you're going to forget about it because that patient you're not going to mess with. But typically where you test thresholds are patients who are, for instance, your congenital heart block who you've put a pacemaker in, or a stable post-op patient, now you've put a pacemaker in. They come back to your clinic, to your pacemaker clinic, and you are going to assess what is his threshold. Because remember, if you have a threshold, let's say your threshold is 2, you set his pacemaker at 3 or 4, right? 1.5 times or 2 times or 3 times. You don't need to set his output at 8 or 9, right? So the importance of threshold is it allows you to set the minimum output of the pacemaker, so it saves battery life. Also, there is an issue when you set high outputs. What can happen if you set an output of, say, 8 volts? What are one of the complications of very high outputs? Anyone? High output you can have. You've heard of diaphragmatic pacing. So you can land up pacing the diaphragm. And therefore, it's not a good idea to just put at a high threshold, a high output and leave them. A high output can pace the diaphragm. It can give them hiccups. It can also use up the battery. And it's unnecessary. And that is why when you have a stable patient who you put your pacemaker, you need to know what is his threshold. What is the minimum amount at which he can capture the myocardium. So, first thing you're going to do, you're going to turn the pacemaker rate up to what of the patient's intrinsic rate. Let us say the patient's intrinsic rate is 70. What do you turn it up to? Anyone? Or is this too much? I'm not sure of everyone's, if I'm going too fast or the understanding. So typically, I'll walk you through this, and then if you need, we'll come back and explain it again. Typically, we go higher than whatever is his intrinsic rate. Then we change the milliamperage until we stop capturing. So what do? We decrease. We keep reducing the voltage. So let's say we are at 9 volts, then 8 volts, then 7 volts, then 6 volts, until we no longer capture the myocardium. Then we slowly increase it again. So let us say at 2 volts we stop capturing, we go back to 3, and we go back to 4. And we slowly increase till you get depolarization after every spike. That means every time you have a pacer spike, now you've got depolarization. So that voltage at which depolarization occurs after every spike is what is called the threshold. Then we go and set the volt to 1.5 to 3 times of that threshold. Is this clear? And then we go back to the pacemaker rate, whatever rate you have determined. So when you are assessing threshold, you have to set your pacemaker at a higher rate than whatever the patient's rate is. Because you say a patient's rate is 60, right? We're not doing backup rates at this point. We are seeing what is the threshold. So we will set the pacemaker rate at 70. That means pacemaker is going to go on beating at 70. And then we reduce till we stop capturing, then we slowly increase till we capture. We have depolarization after QRS, after every spike, and that is our threshold. Then we set our voltage or our output to 1.5 to 3 times the threshold, and then we go back to the pacemaker to its rate of 60 or whatever it was we wanted it at, or a standby rate or whatever that rate may be. Is that clear? Now the same applies for when you do sensitivity testing. Okay, so when you do sensitivity testing, you have to set the heart rate at what? Lower or higher than patient's intrinsic rate? Anyone? Yes, so 10 beats per minute lower. So now when you're doing sensitivity testing, you have to go lower than the patient's intrinsic rate, right? Because you are going to try and assess you set, if the patient's rate is 70, you set your pacing rate at 60. So because you're trying to now sense that heart rate. Now you reduce your output, right? You bring the output all the way down because you now don't want to be capturing, you don't want to be pacing. You don't want patient's intrinsic rate to pace plus your pacemaker. So you bring your output all the way down. Where what was the output? Output was what we just did before this. So you bring your output down to 0.1, very low milliamperage. You can't make it 0 in your output. Now remember again, this testing of sensitivity you cannot do if a patient is pacemaker dependent. So that's why a lot of you wouldn't have done this sensitivity or threshold testing, because you're seeing patients on the pacemaker in the ICU. And on those patients, we cannot be doing all this where they are pacemaker dependent. Those patients, you're going to set their sensitivity at 1 or 2, very low. That means very high sensitivity, very low number. And you're going to put their output at 5 or 6 or 7, enough to capture, and you're going to keep them stable. This is done typically in the outpatient setting when the patient comes back for their pacemaker testing. So it's a good idea for all of you to go find out your EP departments, find out when the St. Jude guy comes, find out when they're doing the pacemaker testing of patients, and this is what you will see. So here you reduce the output to 0.1. Then what do you do to the millivoltage? You bring it down or up? So you keep increasing your millivoltage until your sense indicator stops flashing. That means now it's not sensing anymore. That means you make it 3 and 4 and 5 until it's not sensing, right? Once you see that it's not sensing, again you come down. So let's say at 6 it stops sensing. You come down 5, 4, 3 until the sense indicator, there's that little button which is a red button, which will keep flashing. And that, when it continuously flashes, that tells you, okay, this is the sensing threshold. That means this is the minimum voltage that is needed in order to sense all the time. Then after that, you set your sensitivity, your MV at what? Whatever this threshold you get, you set it at, what do you set the actual sensitivity at? Lower or higher than that value? You set it at half less. So you set it at less than that threshold value, so that you're sure, like, okay, if my threshold value is 3, that means I'm able to sense everything at 3. Let me be safe, Baba. And you set it at 1 and 1.5 or 1. And then you go back to setting the pacemaker to the prescribed rate. Is this clear to everyone? So I would advise you all to spend some time in your pacemaker department, especially this is typically done with your St. Jude's, and the guys come with the equipment. So you sit with them and do it over and over again till it becomes second nature. Okay, so I have a lot more, but it is now 6:20. Okay, we'll do a few more minutes and then we'll stop. So what are the modes of a pacemaker? What do we mean by modes of a pacemaker? Anyone? Mode of a pacemaker. What is a mode? You've heard, you've heard, so we discussed unipolar, bipolar. We discussed dual chamber. So yes, you can have A sense, V pace, or V pace, A sense. But generally, when we talk about modes, we talk about the capabilities of a pacemaker. So is it a fixed rate or is it a demand? Right? So what is that? So when we have DDDR, what is the R? Right? What is the R? It is a rate responsive, right? So fixed rate means if it's in a mode of a fixed rate, that means that you set a rate and it goes on at that rate. Demand mode, when we say the pacemaker is set in demand mode, that means that the demand mode is on demand. That means when it senses something, it paces, or when it senses something, it doesn't pace. So when we talk about V sense, A pace, A sense, V pace, V sense, V pace, all that, right? That is all demand mode, right? We are sensing and then we are responding. So that is what is called your demand mode. Fixed rate is when you're not sensing, you're not getting inhibited, you're just tuck, 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 tuck. So when do you set at a fixed rate? What is your fixed rate? What more? When you remember your VOO, AAI, VDD, which mode is a fixed rate? Fixed rate is your VOO. You just put the output, you put a rate and tuck, 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 you keep pacing. This is typically done like in your post-op heart blocks where you can't take a chance and you as I said, you don't want to check sensitivity, threshold, nothing. You just put a rate and let it pace. So generally fixed rates are not used. More commonly what is used is the demand mode. So the demand mode is where you respond. You respond either to whatever it may be. Okay, it could be exercise, it could be to a certain sensitivity that you want, right? It doesn't matter what you have to set those demands. Fixed rate, on the other hand, will keep firing regardless of heart rate. The danger of fixed rate, of course, is that you can get R-on-T phenomenon. You can suddenly pace when you're in the middle of a repolarization, and you can have a VFib. So fixed rate has certain issues. And demand, on the other hand, will pace only when the patient's heart rate falls below a certain level. And that is your A sense, V pace, or V sense, V pace, or A sense, A pace, right? So it's all your sensing, and then you set it. So when the patient's heart rate goes below a certain level, that is when it is going to pace. Okay? I think I'll do this last concept and then we shall end for the day. So what is hysteresis? What is the concept of hysteresis? Anyone? Hysteresis. So this is again used not in your ICU setting, but it will be used in your elective pacemaker department. Anyone? What is hysteresis? Okay, what does it roughly correspond to in your cardiac electric cycle? Anyone? So hysteresis is basically when you have an intrinsic beat, right? Your own patient has his own beat. Now you sense that beat, then you wait, right? The pacemaker waits. Then it waits to see if patient again has an intrinsic beat. But let us say no intrinsic beat comes. Then finally the pacemaker will pace, right? So hysteresis is that interval from the intrinsic beat to the next paced beat, is set longer than the paced rate. That means, let us say his paced rate is 70 beats per minute, right? But you can set a hysteresis, which means that if that patient has his own intrinsic beat, then you're going to wait a little longer. You're going to wait maybe till what the equivalent of 80 beats per minute, right? You're going to wait, or 60 beats, sorry, 60 beats. You're going to wait for it a little longer before you pace. So what does this do? It allows the intrinsic beat a chance to capture the myocardium and go into a lower rate. So basically you set it at a slightly lower rate. So this is a difficult concept, but it's there in all the new pacemakers. So this basically corresponds in a sense to your AV interval, if you think about it, right? So normally you have your atria beats, for instance, and then your ventricle beats. Now, sometimes in pacemakers, you set a longer AV interval. So if your atria beat, then after a little longer, right, you have a ventricular. You can set your AV interval the way you want. In hysteresis, what you do is you actually set, these are settings within the pacemaker, where you set what is called a hysteresis interval. So the hysteresis interval is greater than your lowest rate interval. Does this make sense? So let us say your pacemaker rate is set at 70. Okay, then that means you will set your hysteresis interval to be a little longer. That means whenever he has an intrinsic beat to his next paced beat, it's going to be longer than the rate interval that you set between two QRSs. So say QRS to QRS is X milliseconds, your hysteresis interval will be QRS to QRS X plus something milliseconds. So that basically once he gets his own beat, the pacemaker will sense, aha, this is not a paced beat, this is an intrinsic beat. Then it will wait a little longer. The pacemaker will wait just a little bit longer, saying, okay, let me see if another intrinsic beat comes. If another intrinsic beat comes, the pacemaker, of course, because it's sensing, it gets inhibited. It waits a little longer. Intrinsic beat doesn't come. It waits just a bit longer. And then it says, okay, intrinsic beat is not coming, and it paces. Now, the danger with hysteresis, and that's why I won't suggest any fellow goes and sets a hysteresis interval is, let us say you set a hysteresis interval that is too long. Now that pacemaker is waiting. Intrinsic beat has come. It has triggered the hysteresis interval. Hysteresis interval is too long, but the next intrinsic beat doesn't come, and now the pacemaker beat is coming too late. You may cause the patient to become symptomatic. So therefore, hysteresis intervals have to be done really very carefully, and it cannot be too long or too much off. So it's generally a couple of milliseconds, couple of seconds if you want, away from a pace rate, not much more than that. Okay, all clear on that? So I think with that I shall end the pacemaker, because that's a lot of information in one day. Let me just see what all we have. Yeah, we've got a whole bunch of other things as well as pacemaker. So I'll do a version, another, maybe next week I'll fix up for the next part of this. So I shall end with that. Just to recap, I'd want you all to go back. Kavita, you can stop recording.